Hello, everyone. Welcome to the second lecture on cardiomyopathy. Here is the table of contents of what we are going to be talking about today. So, what is the definition of cardiomyopathy? Cardiomyopathies are defined as myocardial disorders that result in structural and functional abnormalities of the heart muscle. But these abnormalities occur in the absence of other cardiac diseases that might otherwise explain them, like coronary artery disease, chronic hypertension, or significant valvular lesions. In simpler terms, if the patient's heart looks and behaves abnormally, and that abnormality cannot be fully explained by ischemia, pressure overload, or congenital malformations, you are likely dealing with a cardiomyopathy. This distinction is clinically vital. It separates primary myocardial diseases from the cardiac consequences of systemic or vascular pathology. Also keep in mind that many patients with cardiomyopathy do have comorbid coronary artery disease or hypertension, but the diagnostic threshold is whether those comorbidities are enough to account for the myocardial changes you are seeing. Now that we have defined cardiomyopathy, why does it matter? First, prevalence. Cardiomyopathies are more common than many realize, affecting roughly 1 in 250 individuals globally. That makes them more prevalent than type 1 diabetes or multiple sclerosis. Second, they carry high stakes because cardiomyopathy is the leading cause of sudden cardiac death in young athletes, and often the first manifestation is catastrophic. It is also the most common indication for heart transplant in patients under 65 years of age. And crucially, it is often familial, meaning that misdiagnoses do not just affect one patient, but they affect the whole families. So the main takeaway on this slide is that early identification and family screening can dramatically reduce both morbidity and mortality. So even in primary care, when faced with an unexplained syncopal event, exertional symptom in a young adult, or incidental left ventricular dysfunction, the implications of correctly recognizing cardiomyopathy are far-reaching. Let's zoom out for a moment and take a population-level view. Cardiomyopathies are not a single disease entity, but they actually represent a spectrum of diseases with distinct prevalence patterns, age distributions, and even geographic biases. So let's walk through them. Hypertrophic cardiomyopathy prevalence ranges from 1 in 200 to 1 in 500, making it more common than most people think. It can manifest at any age, but often surfaces in adolescence or early adulthood, particularly in athletic populations. Dilated cardiomyopathy, which is the second one, this is the most common form encountered in practice, and the estimates range from 1 in 250 to 400, typically presenting between ages 20 and 60. Dilated cardiomyopathy accounts for a major proportion of patients referred for transplant evaluations. Next, arrhythmogenic cardiomyopathy, formerly known as arrhythmogenic right ventricular cardiomyopathy. It is a rare condition with prevalence between 1 in 1,000 to 1 in 5,000 and typically presents in teens to early middle age, and it is often the cause of exertion-related sudden cardiac death. Then restrictive cardiomyopathy, which is the rarest form. It is seen in fewer than 1 in 10,000, primarily in the elderly and frequently underdiagnosed until advanced. There is also the peripartum cardiomyopathy, which is a special subtype or a particular subtype of dilated cardiomyopathy, which occurs in about 1 to 1,000 in 1 to 1 in 3,000 pregnancies, typically in the late gestational period or postpartum, and it is increasingly recognized as a phenotype with overlapping features of dilated cardiomyopathy. Now let's turn to how we categorize cardiomyopathies. This matters because classification drives diagnostic strategy, risk stratification, and treatment approaches. So we start with the broadest axis, which is primary versus secondary. Primary cardiomyopathies originate within the myocardium. They are intrinsic muscle diseases. They include classic examples like hypertrophic cardiomyopathy, idiopathic dilated cardiomyopathy, arrhythmogenic cardiomyopathy, and idiopathic restrictive cardiomyopathy. Secondary cardiomyopathies arise from external systemic causes, so think of amyloidosis, sarcoidosis, or hemochromatosis. And in secondary cardiomyopathies, the myocardial dysfunction is a consequence and not the core pathology. Then comes the genetic axis, genetic versus acquired. Many primary cardiomyopathies are genetically driven, so there are some mutations that may be in the sarcomeric proteins or in the desmosomal structures or nuclear scaffolding proteins. On the flip side, some phenotypes are acquired, typically due to infections, toxins like alcohol or chemotherapy, or metabolic insults. This framework helps clinicians decide when to initiate genetic testing, when to screen relatives, and how to counsel patients on disease progression and recurrence. Finally, and most practically, we arrive at the morphologic phenotype classification. This is what you all use at the bedside and in reports, so let's simplify it. Hypertrophic cardiomyopathy is defined as left ventricular hypertrophy more or equal to 15 millimeters, so 1.5 centimeter, which is often asymmetric. It is often asymmetric and can be obstructive or non-obstructive. Red flags include left ventricular outflow tract gradients, exertional syncope, and risk of sudden cardiac death. Dilated cardiomyopathy presents with dilated left ventricle and ejection fraction less than 45%, often accompanied by arrhythmias and risk of thromboembolism. Arrhythmogenic cardiomyopathy is unique. It may involve right ventricle, left ventricle, or both, with fibrofatty replacement leading to ventricular arrhythmias. Look for exercise-induced sudden cardiac death or ECG changes in leads V1 to V3. Restrictive cardiomyopathy features a small, stiff left ventricle by atrial enlargement and preserved ejection fraction that behaves like heart failure with preserved ejection fraction. It's often associated with AV blocks and low voltage ECGs. A newer term worth noting is non-dilated hypokinetic cardiomyopathy, NDHC, which is an early pre-dilated stage of dilated cardiomyopathy, especially in genetically positive individuals. This phenotypic classification is the most clinically actionable as it ties directly into the imaging, management, and device decisions. Cardiomyopathies do not arise in a vacuum. Even genetically driven forms usually require a second hit, like environmental, inflammatory, or hemodynamic, to express their phenotype. So let's break down phenotype by phenotype by phenotype. The genetic drivers for hypertrophic cardiomyopathy are most commonly MYBPC3 and MYH7 mutations. Both are sarcomeric proteins. These are autosomal dominant with variable penetrance. Environmental triggers include hypertension, which may exaggerate the phenotype, and athlete's heart, which can mimic or unmask hypertrophic cardiomyopathy in borderline cases. Dilated cardiomyopathy genetic factors. Up to 30 to 40% of dilated cardiomyopathy is familial. Key mutations include TTN or Titin, LMNA, which is in the nuclear envelope, and FLNC. Environmental insults include alcohol, viral myocarditis, chemotherapy like anthracyclines, and the peripartum state. All are well-documented triggers, and this is why even young, otherwise healthy patients with dilated cardiomyopathy need both family screening and lifestyle workup. The genetic basis for arrhythmogenic cardiomyopathy include PKP2, DSP, DSG2, and TMEM43, which are all affecting desmosomal integrity. The environmental trigger is endurance exercise, which can accelerate disease progression and unmask arrhythmogenic potential. This is one reason why arrhythmogenic cardiomyopathy is often unmasked in athletes during screening or postmortem. The genetic basis of restrictive cardiomyopathy include transthyretin TTR mutations, both wild type and hereditary, along with infiltrative diseases like AL amyloidosis. Acquired causes include radiation fibrosis, iron overload from hemochromatosis, Fabry disease, and sarcoidosis, which can all mimic restrictive physiology. So, when you are in the clinic or in the ward, always think dual axis. So is there a genetic substrate? Has something acted as a phenotypic trigger? And this is the bridge to talking about pathophysiology. Despite phenotypic differences, most cardiomyopathies share a common cascade. They begin with some sort of molecular disruption, which will lead to structural remodeling, then progressive dysfunction, and then electrical instability. What's fascinating is that these changes begin long before symptoms. Subclinical myocardial dysfunction often precedes echo changes, which in return precede clinical decline. And regardless of the initiating mechanism, whether sarcomeric mutation, desmosomal instability, or toxic injury, the ultimate consequences often include fibrosis, neurohormonal activation, and hemodynamic compromise. These downstream effects are what we treat, but the upstream is where prevention and early intervention live. As you can see, the embryologic origins of the myocardium are important to discuss. Why? Because many cardiomyopathies are not acquired diseases, they are developmental miswiring that only manifests years later. The heart originates from mesodermal precursors organized into two cardiac progenitor fields. The first heart field, also known as FHF, and the second heart field. The first heart field forms the left ventricle and parts of the atria, and the second heart field gives rise to the right ventricle, outflow tract, and remaining atrial tissue. These fields coordinate spatially and temporally between weeks 3 to 5 of gestation. Any disruption here, even subtle, can echo into adulthood as structural heart disease. The myocardium's fate is sculpted by key transcription factors. The NKX25 is crucial for early chamber specification and conduction system development. The GATA4 and the TBX5 regulate septation and myocardial structure integrity. MEF2 and MIOCD drive myocyte differentiation and hypertrophic response. Now imagine mutations that impair these regulators that I just mentioned, like for example sarcomeric dysfunction due to MYH7 mutation, which we just talked about, or impaired contractile scaffolding due to the Titin or TTN mutation, or defective nuclear signaling due to the LMNA mutation. Here you can see what I just described in a nice illustration. Now let's re-anchor what we just talked about into all the major 4 clinical subtypes or phenotypes. So hypertrophic cardiomyopathy starts with sarcomeric mutation, usually MYBPC3 or MYH7, and the result is myocyte hypercontractility. But paradoxically, this will lead to asymmetric left ventricular hypertrophy, diastolic dysfunction, left ventricular outflow tract obstruction, and even myocardial ischemia despite clean coronaries. And this is why these patients often have preserved ejection fraction but reduced filling capacity and risk of sudden death. In dilated cardiomyopathy, mutations are in either cytoskeleton or nuclear proteins like TTN or LMNA. This will lead to impaired contractility, and impaired contractility will lead to chamber dilation. The dilated chamber or the dilation stretches on the annular rings of the mitral and tricuspid valves, which can lead to functional mitral and or tricuspid regurgitation, eventually resulting in systolic heart failure, also known as heart failure with reduced ejection fraction, arrhythmias, and thromboembolism from stasis of blood. In arrhythmogenic cardiomyopathy, the cause is desmosomal protein defects like PKB2 and DSP. These chromosomes lose adhesion, which leads to myocyte detachment. And the other thing that will happen is inflammation and fibrofatty infiltration, especially in the right ventricle. And this explains why arrhythmogenic cardiomyopathy is more about arrhythmia and electrical activity even before structural failure sets in. The pathophysiology in restrictive cardiomyopathy is either infiltrative or storage-based. Think of amyloid or Fabry disease. These stiffen amyloid or Fabry. These stiffen the ventricle and reduce compliance, and the result is restrictive physiology, high filling pressure or pressures, low output, and conduction disease. So these mechanisms that we just described in all four major subtypes help you anticipate what symptom will emerge first and what to look for on ECG or imaging, and when to escalate care, especially in early phenotypes like the NDHT that we described, the early stage of dilated cardiomyopathy, or genotype positive, phenotype negative patients. So patients who have positive genotype and negative phenotype. Now that we have mapped the upstream origins and the phenotype-specific cascades, let's tie them together by asking, why do all these cardiomyopathies eventually cause why do all these cardiomyopathies eventually cause some functional problem? Despite their diverse appearance, the downstream story becomes more familiar and clinically predictable. Hypertrophic and restrictive cardiomyopathy both accumulate in diastolic failure, but the mechanism is different. In hypertrophic cardiomyopathy, the hypertrophied left ventricle becomes stiff, and in restrictive cardiomyopathy, the ventricles may appear normal in size, but infiltration of fibrosis restricts relaxation. And the consequence in both is elevated left ventricular end diastolic pressure, pulmonary congestion, and dyspnea with exertion, which is the classic heart failure with preserved ejection fraction physiology. Dilated cardiomyopathy, on the other hand, leads or heads to the opposite direction, because the problem here is actually systolic, not diastolic, unlike hypertrophic cardiomyopathy and restrictive cardiomyopathy. So the ventricles will dilate, the ejection fraction drops, and stroke volume will decline as well, and this will lead to compensatory neurohormonal activation, adverse remodeling, and the full syndrome of heart failure with reduced ejection fraction, like orthopnea, edema, fatigue, and so on. Arrhythmogenic cardiomyopathy, interestingly enough, may preserve ejection fraction for a long time, but it is electrically unstable. Why? Because the fibrofatty infiltration on the right ventricle and sometimes the left ventricle predisposes to malignant arrhythmias, often with no preceding drop in systolic function. And this is the classic cause of sudden death during exertion in seemingly healthy young people. So, just to refresh, hypertrophic and restrictive cardiomyopathies both lead to stiff ventricles and diastolic failure. Dilated cardiomyopathy leads to weak ventricles and systolic failure, and arrhythmogenic cardiomyopathy leads to electrical instability. Despite their differences, all cardiomyopathies converge into, or eventually will come into, one shared pathophysiologic endpoint. And to understand it, we can divide it into 5 endpoints. Number 1, fibrosis. And this is universal across all phenotypes of cardiomyopathy. And on cardiac MRI, you can see something known as LGE, which stands for late gadolinium enhancement. So the fibrotic tissue will take the gadolinium, and this will lead to enhancement of the cardiac MRI. Fibrosis impairs contraction, disrupts conduction, and sets the stage for arrhythmias, of course, because fibrotic tissue is slower in conduction. Number 2, atrial remodeling. As the left ventricle filling pressure rise, the left atrium will dilate, and this will promote atrial fibrillation, which further impairs ventricular filling and increases the risk of stroke. 3, neurohormonal activation. Through the activation of RAS and the sympathetic nervous system, they become chronically activated, especially in dilated cardiomyopathy, and this perpetuates volume overload, vasoconstriction, and adverse remodeling. In some phenotypes, there might be also systemic involvement, especially in infiltrative and genetic subtypes. For example, amyloidosis cardiomyopathy can also present with neuropathy, proteinuria, carpal tunnel syndrome. LMNA mutations can lead to skeletal myopathy. Fabry disease can lead to angiokeratomas and GI symptoms. Last but not least, thromboembolism, which is arising from stasis of blood flow from the left ventricular dysfunction, especially in apical aneurysms or marked dilation. In apical aneurysms or marked dilation, which will promote clot formation. Atrial fibrillation as well in hypertrophic cardiomyopathy or restrictive cardiomyopathy is another high-risk setting for thromboembolism. Now let's talk about clinical features. Number 1, dyspnea on exertion, and this is the most ubiquitous form or the most ubiquitous symptom, and it can be seen both in diastolic dysfunction and systolic failure, so in both hypertrophic restrictive cardiomyopathies and dilated cardiomyopathy. Number 2, fatigue and reduced exercise tolerance, especially in dilated cardiomyopathy or peripartum cardiomyopathy, where forward output is impaired due to the ballooning of the left ventricle. Palpitations, and this should always raise red flags, particularly in arrhythmogenic cardiomyopathy, because this is often the first symptom in arrhythmogenic cardiomyopathy, and advanced dilated cardiomyopathy, in which there might be ectopy and non-SVT and so on, and in hypertrophic cardiomyopathy, especially with left ventricular outflow tract obstruction. Chest pain is more common in hypertrophic cardiomyopathy, even in the absence of coronary artery disease, and it results from demand-supply mismatch and small vessel ischemia. Syncope or presyncope is a huge red flag in cardiomyopathy, because, for example, in hypertrophic cardiomyopathy, it can indicate left ventricular outflow obstruction or ventricular arrhythmia, and in arrhythmogenic cardiomyopathy, you have to think of sudden arrhythmic episodes, especially during exertion. Edema and ascites is more common in restrictive cardiomyopathy and advanced dilated cardiomyopathy, where the right-sided pressures build up. In hypertrophic cardiomyopathy, some physical signs observed in clinical examination may include bifid carotid pulse, which is described as the classic spike and dome pulse due to dynamic outflow obstruction, as well as dynamic systolic murmur, which is best heard at the left sternal border, which increases with Valsalva, maneuver. In dilated cardiomyopathy, the apex might be displaced and diffused. You might hear also S3 gallop, which is an early marker of volume overload. You might also hear pulmonary crackles or rails, pedal edema, and sometimes functional mitral regurgitation from the annular ring dilation. In arrhythmogenic cardiomyopathy, you might find right ventricular heave, jugular venous pressure elevation. On ECG, you might see epsilon waves, which are subtle but pathognomonic finding. Palpable signs may be minimal in arrhythmogenic cardiomyopathy unless right ventricular failure is advanced. In restrictive cardiomyopathy, we might see the Kussmaul sign, which should not be confused with Kussmaul breathing. That is something else. Kussmaul sign is paradoxical rise in jugular venous pressure with inspiration when you take breath in. Ascites and peripheral edema are often more marked than pulmonary congestion, and the left ventricle may feel normal in size, but filling is heavily restricted. Age-specific clues are a very powerful tool for age profiling. For example, neonates and infants may present with failure to thrive, tachypnea, and hepatomegaly, and this is most often linked to dilated or metabolic infiltrative disease. Children and adolescents may present with exercise-induced syncope or sudden death, and you have to think of, especially of hypertrophic cardiomyopathy or arrhythmogenic cardiomyopathy, especially in athletic children with a positive family history. In young athletes in their 20s or 30s, new onset heart failure symptom plus arrhythmias give the suspicion that there might be dilated cardiomyopathy or arrhythmogenic cardiomyopathy, particularly if previously undiagnosed. In elderly, heart failure with preserved ejection fraction plus neuropathy or bilateral carpal tunnel syndrome can point out to a transthyretin amyloid-related restrictive cardiomyopathy, which is one of the most underdiagnosed causes of heart failure in older patients. Now that we have covered the signs and symptoms, let's walk through a systematic diagnostic approach, not just for identifying cardiomyopathy, but for differentiating between its subtypes, underlying causes, and familial implications. There is a very common practical framework known as the ABCDE plus G framework, where A means anamnesis, and basically that means history and physical exam. You do targeted history, and not just for the patient, but for an entire 3-generation pedigree, looking for if there is any history of sudden cardiac death, family history of sudden cardiac death before the age of 40, or unexplained heart failure, or ICD implantation, or syncope, and even some environmental factors like alcohol, drinking too much alcohol, or chemotherapy, or viral illnesses, or history of intense athletic activity. B is for basic tests like NT-proBNP, BNP, and HS troponin for myocardial stress and injury. Also, you can screen for secondary causes like hemochromatosis or amyloidosis through ordering ferritin, creatinine kinase, free light chains, and metabolic panel. You can also do resting ECG plus or minus Holter to detect arrhythmias, conduction delay, or pathognomonic signs like the epsilon wave or the Q waves, as we will see. C is for cardiac imaging, and this is where we get phenotype defining data. This is where we start to get phenotype defining data. The first line is TTE, which is transthoracic echocardiogram. It assesses the ejection fraction, the wall thickness, the chamber size, the valvular function. Then CMR, cardiac MRI, which provides advanced tissue characterization, like for example the LGE that we talked about for fibrosis, late gadolinium enhancement, also T1 and T2 mapping for infiltrative disease, and fat infiltration in arrhythmogenic cardiomyopathy. We can do also some technetium scintigraphy, especially for differentiating transthyretin from AL amyloidosis. D stands for directed genetics. Genetic testing should be guided by phenotype. For example, sarcomere panel for hypertrophic cardiomyopathy, TTN-LMNA, and FLNC panel for dilated cardiomyopathy, desmosomal genes for arrhythmogenic cardiomyopathy, and TTR sequencing for hereditary amyloidosis. If the phenotype is unclear or the panel is negative despite strong suspicion, we might escalate to exosome or genome sequencing. Then the E stands for etiology-specific testing, which is reserved mainly for unusual or unresolved cases, like for example endomyocardial biopsy, which is particularly suspected in myocarditis or some infiltrative disease. Enzyme assays as well, like to detect Fabry disease or Pompe's disease or some mitochondrial disorders. Autoimmune panel and viral PCR if there is red flags for inflammatory cause. We can also do genetic counseling, and this should not be overlooked because it interprets the variant of interest, it arranges the cascade screening for relatives, and it assists in reproductive planning. So, for example, pre-implantation genetic diagnosis. Pre-implantation genetic diagnosis. Let's anchor this diagnostically. So, what ECG pattern clues us into each type? In hypertrophic cardiomyopathy, there will be something known as the left ventricular hypertrophy pattern, which is described as tall R waves in V5, V6, and deep S wave in V1. There might be also something known as deep Q waves, also known as dagger-like Q waves in the inferolateral leads. Repolarization abnormalities might occur, like T wave might be observed, like T wave inversions. Atrial fibrillation is common as well in advanced stages. In dilated cardiomyopathy, there's usually sinus tachycardia, which is the first clue in young patients. You might also find QRS widening with or without left bundle branch block, low voltage in advanced cases, and even sometimes atrial fibrillation or non-SVT, NSVT, may appear later on. In arrhythmogenic cardiomyopathy, there is a classic epsilon wave or epsilon waves in V1 through V3 to V3. They are small positive deflection buried at the end of the QRS. T wave inversions as well might be seen in right precordial leads, and prolonged S wave upstroke in V1 to V3. In restrictive cardiomyopathy, the QRS will be low voltage despite thick-looking myocardium on imaging. There might be also something known as pseudo-infarct Q waves in lateral leads, and in some cases also AV blocks or bundle branch blocks due to infiltration of conduction pathways. Here you can see the classic septal Q waves in hypertrophic cardiomyopathy. You can also see the flat T waves and the low voltage QRS and so on in dilated cardiomyopathy. You can see the epsilon wave after the QRS in arrhythmogenic cardiomyopathy. And here's how restrictive cardiomyopathy looks. Very low voltage QRS with some conduction delay, especially it might be seen in sarcoidosis, third degree atrioventricular block. Echo remains the cornerstone of diagnosis, especially in resource-limited settings, but interpretation must be phenotype aware. So in hypertrophic cardiomyopathy, you might find asymmetric septal hypertrophy, another thing known as SAM, systolic anterior motion of the mitral valve, and this basically means that during systole, the right leaflet of the mitral valve might come into contact with the ventricular septum. Also, you might find dynamic left ventricular outflow tract obstruction, which can be worsened by preload reduction or exercise. In dilated cardiomyopathy, you will find dilated left ventricle, reduced ejection fraction, as we said, less than 45%, and global hypokinesia. The movement in the left ventricle is slower. You may also see functional mitral or tricuspid regurgitation, as we mentioned, due to annular dilation. In arrhythmogenic cardiomyopathy, there might be right ventricular dilation, akinesia of the right ventricular wall, and the left ventricular involvement is increasingly recognized, although not very significant for now. Also, in restrictive cardiomyopathy, you might see biatrial enlargement, as we said. The atria, both of the right and the left atria, will be enlarged. You will find normal wall thickness, but there is restrictive filling pattern. And if you do tissue Doppler, it will show an EE ratio of more than 15, which basically describes the filling pressures, so very high filling pressures, and low E velocities. The takeaway is that echo gives you structure and flow, and cardiac MRI gives you tissue and etiology, and together they triangulate the phenotype and often guide therapy. Let's go to management. Management is divided into three: lifestyle, pharmacologic, device, and there are also some interventions in some cases. Exercise recommendations must be tailored to phenotype and risk profile. For example, in arrhythmogenic cardiomyopathy and high-risk hypertrophic cardiomyopathy, competitive sports are contraindicated, and the risk of exercise-induced ventricular arrhythmia or sudden cardiac death is very high. For hypertrophic cardiomyopathy patients with left ventricular outflow tract gradient less than 30 mm mercury who are asymptomatic and low risk, moderate aerobic activity is acceptable, but only after full evaluation. For advanced heart failure stages, we should aim, which is often seen in dilated cardiomyopathy and restrictive cardiomyopathy, we should aim for a total amount of sodium per day less than 2 grams and fluid restriction less than 1.5 liters per day, particularly in volume-sensitive patients. And all cardiomyopathy patients should receive annual influenza, COVID-19, and pneumococcal vaccines, not just for infection prevention, but to minimize cardiac decompensation during febrile illnesses. Also in pregnancy, we must continue teratogenic medications like the RAS inhibitors, all of them. And metoprolol succinate is the preferred beta blocker if one is needed for rate control or outflow gradient. And close monitoring is required for women with known cardiomyopathy, especially in hypertrophic cardiomyopathy and peripartum cardiomyopathy cases. Let's organize pharmacologic therapy by therapeutic class, then align them with indications and dosing. Number 1, beta blockers like metoprolol succinate and bisoprolol. They are indicated in hypertrophic cardiomyopathy to reduce symptoms by lowering heart rate and left ventricular outflow tract gradient. In dilated cardiomyopathy as part of the GDMT, which I explained in the heart failure lecture, guideline-directed medical therapy, and the typical dose of metoprolol is about 25 to 200 milligrams per day, which is titrated according to the heart rate and the tolerance. Second of all, RAS inhibitors, especially the ARNIs like sacubitril and valsartan, and they are the mainstay of treatment in patients who have dilated cardiomyopathy with heart failure with reduced ejection fraction. We start usually at a dose of 24 over 26 milligrams BID, and we reach a target of 97 over 103 milligrams BID. Then mineralocorticoid receptor antagonists like spironolactone and eplerenone, they are indicated in dilated cardiomyopathy with ejection fraction less or equal to 35%. And the dosing of spironolactone is usually between 12.5 to 50 milligrams per day. Then the SGLT2 inhibitors like dapagliflozin and empagliflozin, they are indicated across all the spectrum of heart failure, as we said in the heart failure lecture. And they are here also indicated in dilated cardiomyopathy, in peripartum cardiomyopathy. And the typical dose is 10 milligram once daily. We can also use diuretics for symptomatic volume overload. For example, furosemide, we start at 20 to 40 milligrams per day and titrate up as needed. We can also use ivabradine only in heart failure with reduced ejection fraction patients with heart rate more or equal to resting heart rate more or equal to 70% beats per minute in sinus rhythm, so there is no atrial fibrillation, despite giving or administering max tolerated beta blocker dose. And the typical dose of ivabradine is between 5 to 7.5 milligrams BID. Beyond these conventional agents that we talked about, there are some novel targeted therapies that are becoming increasingly important in subtype specific care. For example, myosin inhibitors like mavacamten. They are indicated in obstructive hypertrophic cardiomyopathy, especially NIHA class 2 and 3 with persistent LVOT gradient. And their mechanism is that they work by reducing hypercontractility, the sarcometic or the myocyte hypercontractility, and they also reduce the LVOT gradient, and the typical dosing is 5 to 15 milligrams per day. There are also the TTR or transthyretin stabilizers like tafamidis for transthyretin-related restrictive cardiomyopathy, and they reduce hospitalization and mortality in NIHA class 1 and 2, and the typical dosing is 61 milligrams daily. Last but not least, in some severe cases of peripartum cardiomyopathy, bromocriptine can be used, often with thrombus prevention, and it acts by suppressing prolactin, which may be cardiotoxic. Sometimes anticoagulation is indicated, for example, in atrial fibrillation, especially in cases of hypertrophic or restrictive cardiomyopathy. Also in left ventricular thrombus or apical aneurysm in dilated cardiomyopathy, for example. Also in left ventricular appendage thrombus. And the preferred agents are the DOACs or the daily oral anticoagulants like apixaban and rivaroxaban, unless contraindicated. We can also use some device-based therapies. There are also some interventions like septal reduction therapy for hypertrophic cardiomyopathy. There are two types: alcohol septal ablation and surgical myectomy. Alcohol septal ablation is for more suitable anatomy, and surgical myectomy is preferred in younger or more complex anatomy cases. We can also do VT or VTAC ablation in scar-mediated VTAC, especially in arrhythmogenic and dilated cardiomyopathy unresponsive to medication. And in advanced heart failure, we might consider left ventricular assisting device or transplantation, especially in refractory NIHA type class 4 symptoms or VO2 less than 12 milliliter per kilogram per minute, or high risk genetic markers like the LMNA that we talked about, or progressive right ventricular failure in arrhythmogenic cardiomyopathy. There are special considerations like cardiomyopathy in pregnancy, as well as cardiomyopathy in pediatrics. Here are some guidelines and some scenarios on when athletes should return to play. And how do we prevent? By doing something known as cascade family screening. So, if the relative is first degree, more or equal to 10 years of age, the baseline test is echo, ECG plus echo, plus or minus phenotype focus panel, and the follow-up interval should be every 1 to 3 years. And if the patient is less than 18 years, it can be annual, so each year. If the relative is gene positive, phenotype negative, we do ECG plus echo plus cardiac MRI at baseline, and the follow-up interval with echo and ECG would be every 12 to 18 months in adolescents and every 3 to 5 years in adulthood. Also, for pregnancy planning, we have to do some baseline tests, echo plus or minus Holter, and medication review per trimester if there is high risk. And a key point to remember is that early detection in early generations or relatives cuts the risk of sudden cardiac death by more than 60% in observational cohorts. Also, we can do athlete and occupational screening according to age or population. Here are some key references used to make this presentation. Thank you all for your attention. If you have any questions or suggestions, you can reach me at my email. And thank you for listening.